College at UNMC. And I really want to acknowledge all of the effort she has put forth in developing our high dose rate prostate brachytherapy program. And I look forward to her presentation today on the initial experience of starting an intraoperative ultrasound guided prostate HDR brachytherapy program from a physicist perspective. I'm also biting my lip to hear what she has to say.
Thanks, Dr. Rankin. Thanks for saying that mouthful for me. So to start, I have no conflict of interest. So high dose rate prostate brachytherapy, needles are temporarily inserted transperineally into the prostate using a transrectal ultrasound for guidance. The needles are then connected to an afterloader, and a radioactive iridium-192 source travels through each one of the needles, delivering radiation to treat the prostate. HDR brachytherapy is commonly delivered as a monotherapy, a boost in combination with external beam radiation therapy, and can also be used as a salvage treatment for patients who have failed other therapies. So there are a variety of different ways you can perform this treatment, but basically all workflows utilize ultrasound guidance to place the needles within the prostate. However, you can utilize CT, MR, or ultrasound to obtain your 3D image that you need for your dose calculation. So CT, MR methods give you great image quality, but you typically have to move the patient for imaging and possibly again for treatment. So this can increase their procedure time, and then also can cause positioning uncertainties. So an alternate option, which is what we're using here, is to acquire a 3D ultrasound image using that transrectal ultrasound already in place. So that way the whole training or planning and treatment process can be done without moving the patient. So just some background on our program here at UNMC. We transitioned to HDR treatments in April of 2019. And to date, we've treated 80 boost patients who get one treatment of 15 gray, and then 2 salvage patients who get 2 treatments of 13 gray. And we're typically treating about 1 to 3 patients per week now. And initially we were only treating 1 patient per day, but now because of increased efficiency, we've started to sometimes treat 2 patients per day. And then immediately following the HDR procedure, our patients will typically have spacer and fiducials implanted for their external beam radiation treatments. Now, I want to be sure to mention that these treatments really do take a village, and there are many different groups of people that are essential to the workflow. However, today I'm just going to narrowly focus on the role of the medical physicist in the treatment workflow and talk about, some of the challenges we have encountered and practical tips and tricks we've learned along the way to overcome them. So the first necessary step to starting any program is to gather all the necessary equipment. So the major items you're going to need are a transrectal ultrasound unit, a stepper, a needle template, a treatment planning software, and then an HDR afterloader. So here we're using a BK ultrasound and an Elekta on Centra prostate as our treatment planning system. And then there are also various other phantoms and single-use supplies and other equipment that you'll need as well, which I'll mention more later. So next you'll need to perform a series of commissioning tests to ensure the functionality and accuracy of your treatment planning system, as well as your ultrasound system. Most of these tests are actually pretty similar to all the commissioning tests you'll need for any brachytherapy program, but there are several unique aspects such as the template calibration, the stepper mechanical accuracy, connectivity between the planning system and the ultrasound, and then the ultrasound image quality. And then other important aspects of the commissioning process are the creation of a process map and performing an FMEA, the development of policies, procedures, and checklists, which is my specialty, and then performing a dry run. So we found the dry run to be one of the most important aspects, and we recommend making it as close to the real process as possible with all involved groups of people participating. So here you can see us performing a dry run in the OR following full sterile procedure and then using a phantom in place of a patient. So in the next section, I'm going to go through the basics of our treatment workflow. Now, because this is a relatively complex and time-critical procedure, we've kind of developed and honed this really detailed checklist for the whole workflow, and it's then later uploaded to the patient's chart. So once we get all our equipment set up in the OR, we're going to perform our daily spot check QA. We're going to prepare the documentation and software for the patient. We're going to test our linear and rotational functionality and accuracy of our ultrasound motor using some built-in testing software. Next, we prepare the brachy balloon, which is just an ultrasound probe cover that can be filled with saline on one side. So this is going to ensure that you have good contact with the patient's surface and can also be used to adjust the height of the prostate relative to your needle template. And then it's very important that that all bubbles are removed from the balloon, or else it can cause imaging artifacts. During this time, the sterile OR nurse or surgical techs are prepping all of these sterile supplies, and they're going to assemble our needle template. Once it's assembled, we have them test the locking mechanism, and then we also have them make sure the washers on the legs here have not moved, because that defines the calibrated height of our template. Once the patient arrives, they're going to be put under general anesthesia, and a paralytic is used to ensure that they're not going to move during the procedure. They're placed in the dorsal lithotomy position. A Foley is placed, and then the perineum is prepped with iodine. And then if they have not followed their bowel prep instructions, it's really important that you suction the rectum to ensure there's good ultrasound image quality. The stepper is then attached to the bed, and the ultrasound probe can be positioned within the rectum. So essentially the stepper is a device that just attaches to the bed, and it's going to hold our ultrasound probe and our template in place. It has a motor that allows you to acquire images and move the probe using the treatment planning software. And then also has a linear encoder as well that's used to track the depth of the probe in the patient. So when we're positioning the probe in the rectum, you want to be sure to center the prostate laterally in the template grid. You want to set the vertical height of the bottom row, make sure it's well positioned a few millimeters above the posterior edge of the prostate, which we'll talk more about later. And then you want to ensure there's just no general ultrasound artifacts, and that the whole prostate is visible, plus some margin on each side. Next, we're going to perform our pre-plan to determine where we want to place our needles. So the pre-plan involves acquiring a 3D ultrasound, contouring, choosing the needle positions, and then optimizing the plan to ensure it's going to meet all the constraints. So now we're ready to acquire our first pre-planned 3D ultrasound image. So in this animation, you can see that the ultrasound probe rotates and acquires a series of radial scans, and it then can be reconstructed to form a 3D image in the ultrasound prostate system. So once you acquire your ultrasound image, you want to scroll through all the slices and make sure you can see the prostate well and that there's no overly obstructive artifacts. So for example, here you can see that some artifacts that can occur when there's maybe an air bubble in the rectum or air bubble in the brachy balloon, or gas in the rectum, or maybe just bad contact between the probe and the rectum. Next, the physician is going to contour your prostate CTV, which is shown in red. And because this is just a pre-plan, we recommend not spending too much time on this, just contouring a few slices. The PTV, which is shown in white, is then created using a 1 to 3 millimeter asymmetric expansion of our CTV. And then lastly, the urethra is contoured, which is shown in yellow. Other contours like the bladder and the rectum can be contoured, but we generally don't, just to save a little time, and don't find them especially useful at this point. So the next step is to choose our needle locations using this virtual template grid that is overlaid on our image that's shown in red here. So here are some of the recommended guidelines for needle placement. So you want to use about 10 to 20 needles and follow an approximate peripheral loading pattern. You also want to try and space them out well and avoid radially overlapping needles to prevent shadowing artifacts. As you can see here, we've developed a couple of template loading patterns, but generally you have to kind of use your best judgment and adapt it to the size and shape of the prostate, since you can see it can vary a lot from patient to patient. So on-center prostate will also display X's on the grid positions where the urethra contour passes through to ensure that needles aren't being placed in the urethra. So here you can see on the left, it may only block the anterior aspect of the central row, or if there's a wide urethra or one that varies a lot laterally, it could block several rows, which makes the needle placement kind of challenging. And then lastly, another key thing you want to pay attention to is the location of the bottom row of the template so that it's a few millimeters above the posterior edge of the prostate. And so this is basically just going to ensure that that row can be used to cover the prostate well without giving too much dose to the rectum. The last step of the pre-plan is to optimize and calculate the dose and ensure that our needle placement is going to give us a good plan. So on-center prostate uses an inverse optimizer with specified dose volume constraints, and also has other manual and graphical optimization options too. So the next step is to insert our needles. In the software, you can navigate to the first needle in the axial view of the 3D image, and then also view a live sagittal ultrasound to ensure that the needle is being inserted in the desired location. So in the video, you can see that the needle position can be adjusted slightly to match where that needle then actually went. You can note in the upper right-hand image here that as needles are placed, so this can sometimes push the prostate more superior. So to try and mitigate this effect, we will insert 2 stabilization needles prior to the needle insertion. And on this right image here, you can see that those needles have a barb that can be deployed to stabilize the prostate and can be used to pull it back more inferiorly if needed. Now, one challenge is that the needles are not always going to go where you expect them to go. So to help with that, we have this tool called a diddler, which is placed between the template and the patient's surface. And you can just use it to push or pull the needles in the desired location. And I'd say we probably use this at least once per patient, if not more. Another one of our most common challenges with needle insertion is pubic arch interference, where the pubic bones will partially block the anterior portion of the prostate. So some ways to minimize this are to angle the patient's legs farther back, reduce the filling of the brachy balloon, change the angle of your ultrasound probe, use that diddler to try and bend the needles underneath the pubic arch, or simply adapt your plan and try and choose new needle locations like you can see in the left image here. So after all the needles are inserted, we'll quickly go back through all the needles one by one and perform a final push so that the needle tip is going to be at least 6 millimeters past our base plane. The metal obturators, which stabilize our plastic needles, are then removed, and we fine-tune the reconstruction as they're pulled out. Lastly, the stabilization needles are removed, and the template is locked so that the needles are locked in place. Next, we perform our final plan, and these steps are identical to our pre-plan, except now we're going to reconstruct where the needles actually went. So after acquiring a final image, because the image quality can degrade significantly on the final ultrasound image due to the needles, we use the pre-planned CTV contour, shown in pink here for a guide for contouring. Again, the CTV is expanded to make a PTV, and then now this time the urethra, bladder, and rectum are all contoured. Next is the needle reconstruction. It's going to be adjusted based on the positions in that final ultrasound image. And I would say this is arguably the most challenging part of our workflow for physicists, just because of that poor image quality after the needles are inserted. So for example, here you can see there can be calcifications or reflections from lower needles that make it challenging to know which of those bright spots are actually real. Additionally, sometimes the needles can appear nearly invisible because they're going to be shadowed by a needle below it. So we found the best way around this is to quickly go back to live imaging mode, reinsert our obturator, and then wiggle it around a bit until we can see it. I'd say we typically have to do this at least once per case, if not more. So next, the free length, or the length of needle that's sticking out from the template, is physically measured with a ruler, and that's going to be entered into the treatment planning system. So this is used to more precisely define the depth of the needle, since we trust this physical measurement more than the tip identified in the ultrasound due to that kind of poorer image quality. Next, we then optimize and calculate our final dose distribution. And then the dosimetric data can be easily copied and pasted from Oncentra Prostate into our dose evaluation worksheet, where it's going to show whether or not we're meeting all of our dose objectives. And we use dosimetric guidelines from the ABS, RTOG 0321 and 0924, as well as ones recommended from other institutions. So once the plan is acceptable and approved, the steps to prepare the plan for treatment are pretty similar to other HDR treatments. We perform a second check of the dose calculation using a in-house software, and then we perform a full plan second check. The transfer tubes are connected to the needles and the afterloader, and then a check cable run is performed to make sure there aren't any obstructions. And then lastly, a survey and other safety checks are completed. Then everyone leaves the room for treatment, and this typically takes about 10 to 20 minutes, depending on the size of the prostate and strength of the source. Anesthesiology can easily monitor the patient remotely and the patient's vitals, and we can always pause the treatment at any time if they need to run in. All right, so in this last section, I'm going to talk about some of the retrospective analysis that we've performed looking back on those first 80 boost patients we've treated. So one unique thing about our workflow is that the plan and dosimetric data is copied into a tracking spreadsheet during each case, and then an in-house script can be run at any time to analyze that data. So here you can see we can easily track things like the min, mean, max, standard deviation of all of our dosimetric goals. So for example, we shoot for a PTV V100% coverage to be greater than 90 to 95%. And on average, we're covering about 94.3 plus or minus 2.2% of the prostate volume. We can also track how often we're reaching our goals, where the ones shown in red are the primary ABS RTOG constraints. You can see we're always meeting our urethra constraints because that's our most critical organ. We're meeting our PTV coverage goal in about 97% of the patients. And then we do struggle a bit with the bladder and rectum. V75% goal is a little more, only meeting the bladder goal 75% of the time and the rectum goal 59% of the time. So to dive into that a little deeper, we can look at histograms of each of those dosimetric goals for each ROI, which allow us to see kind of how it's spread out. So for the bladder V75, you can see that almost all of the cases that aren't meeting are only just over 1 cc. And then similarly for the rectum, all the cases that are not meeting are still within 1.5 cc here. And then additionally, we generally prioritize PTV coverage over the rectal dose, since these patients are going to have spacer implanted, which is going to reduce their external beam rectal doses. We can also plot our dosimetric goals over time and ask, are we getting better at planning over time? So here you can see there's a slight trend and improvement in our PTV coverage, as well as these primary normal tissue constraints. However, generally these outliers are due to patients with difficult anatomy, and that can kind of happen at any time. We've also been tracking the differences between the measured and reconstructed needle-free lengths. You can see that about 81.5% of the lengths agree within 5 millimeters of each other. 10% agree between 5 to 10 millimeters, and then the other 8.6% are larger than 10 millimeters. And then on the right here, you can see that sometimes large discrepancies can occur because things like the needle might extend beyond the ultrasound image. The needle might be completely shadowed and you can't see it well, or the signal just drops out due to an artifact. We can also track plan stats like the number of needles. So you can see on average, we used about 17 needles per plan. And then as you'd expect, larger prostates tended to need more needles. And then interestingly, presumably because we're getting more skillful at the needle placement over time, we're tending to use less needles over time as well. And then lastly, a very important aspect of performing a procedure in the OR while the patient is under anesthesia is procedure timing. So here you can see the procedure duration from patient arrival to dismissal has notably trended downward over time. From our first patient that took nearly 9 hours to our fastest so far, which is just over 2.5 hours. So this is what's allowed us to now start treating 2 patients per day. And we've also collected data on the timing of each of the sub-steps of the procedure. And you can see that for every single sub-step, the duration has been trending downward. Most notably for the patient prep time, needle insertion time, and then needle reconstruction time. And then interestingly, there was a time period in the very beginning for 15 patients where we attempted to skip the pre-planned process and insert the needles on the fly to try and save time. However, as you can see, this actually resulted in an increase in the needle insertion time and reconstruction, as well as the final contouring and planning time. So that ended up negating any time saved not doing a pre-plan, unfortunately. And so here's a summary of these kind of common challenges we encountered and some of these things that have commonly slowed us down. I won't go over them here since we've talked about them throughout the talk. I just kind of want to have them listed in one place for reference. So as we go forward, we hope to continue to optimize the workflow and improve our efficiency, maybe perhaps start seeing 3 patients per day. We'd also like to perform some retrospective replanning studies. So maybe investigating the impact of that needle positioning uncertainties like the free length. And then also re-optimizing the plan to see if we could have done better, maybe just with a little more time spent on optimization or adding a couple needles. I also want to look into summing up the prostate HDR and external beam EQD2s, which is something that's already the clinical standard in things like GYN HDR. And then lastly, I want to see if we can incorporate some deformable MR ultrasound image registration to help us more accurately delineate the prostate. And that's it. Thank you everyone for attending, and thanks to our awesome prostate HDR team here at UNMC.
Well, thank you very much, Abby. I'm actually really pleased to also introduce our next speaker, who's going to look at really our kind of translational research program and the investigators that we really rely on in the Fred and Pamela Buffett Cancer Center in order to really translate things to the clinic. And so I have the pleasure of introducing Dr. Partha Sarathy, Seshacharula, sorry,
yeah.
who goes by Partha.
That's right.
And he is going to discuss today farnesyl diphosphate synthase as a novel target for radiosensitization of prostate cancer. Sartha, go ahead, please.
Yeah, thank you, sir. Thanks for the nice introduction. And can you see my slides?
We can. You're put it in meeting or slide mode. So the slides were there. You just needed to put it in screen mode.
And that'll be the image on the bottom right of your screen that looks like a slide projector.
Just a minute.